Good morning everyone. I'm Dr. Satish Kriplani. I'm a spine surgeon working at Health One Super Specialty Hospital. So I'm going to present a case which I think I was lucky to be a part of when I was in Delhi working with Dr. Arvinder Singh Chhabra. So this is the case, 56-year-old male, chin to chest deformity in a known case of ankylosing spondylitis since 20 years, and it was gradually progressive. The patient did not have any horizontal gaze. The chin draw angle was 94 degrees. So, this is the clinical image, no horizontal gaze at all, 94 degrees chin draw angle. So this was, the deformity was one of the first thing that he came to us with. It was, he came to us in September 2024 with the complaints of bilateral upper limb weakness and clumsiness. The patient was not able to button and unbutton shirt, gait instability, he was not able to walk even for 100 meters without support. On neurological examination, the patient had tetraparesis and the MGO at that time was 9/18. So we did an MRI, which was very difficult for us. The patient, as you can see on the MRI, the patient has a compression at the CV junction, and due to that he had myelopathic symptoms. Now the issues were how to position for upper cervical surgery, should a deformity surgery be done along with the OC fusion, and general anesthesia challenges. So we did this OC fusion in the sitting position. So this was a unique position that we tried, and the position itself took us 3 hours to establish. And we did an OC fusion. This is the X-ray, post-op X-ray. The patient came back to us in November 2024 with recovery in gait instability, resolution of upper limb symptoms, and MGO at that time was 16/18. Now, 1 month later, now considering ankylosing spondylitis, the whole spine gets fused. The only joint which was mobile was the upper cervical joint, atlantoaxial, and the OC joint, occipito-atlantal joint. And we had fused that as well. So the patient, the minor modifications which he was able to do before, he was not able to do that as well. So now he came to us with the complaints of low horizontal gaze, difficulty in walking, sitting, eating food. So in December 2024 he presented to us. Neurological examination was unremarkable at that time. So this was the X-ray. The Cobb's angle was 100 degrees at that time, thoracic hyperkyphosis. So issues, positioning of patient, which osteotomist to do, which level to aim at, correction maneuvers to use, counseling the patient and the relatives, how much correction to aim, and again general anesthesia problems. We did a review of literature. These were 2 papers which we came across. In the first paper there was C6, they did a stage surgery, C6 pedicle subtraction osteotomy, followed by T11, T12 PCR, and then L3 PSO. And the other paper was case series of 12 patients where osteotomies were done in lateral decubitus position. So, stage 2, deformity correction, he came to us approximately 6 months later, and we decided to do it in lateral position. So this was the position that we got. We achieved this position on a bariatric surgery table. So step 1, right lateral decubitus position, midline skin incision, and left T6 to T8 and T10 to T12 pedicle screws with T9 hemicorpectomy was done. Temporary closure, shift to another side, left lateral decubitus and put the opposite side pedicle screw, complete the hemicorpectomy, and we inserted a mesh cage followed by bone grafting. Various correction maneuvers we have used, cantilever, followed by compression maneuvers, external manipulation of the pelvis and thorax from the opposite side to get the sagittal alignment. During sequential compression, we noticed a drop in the motor unit potential, but necessary steps were taken and the situation got under control. So this was the clinical image, and this is the final image, improved balance, functional capacity and gaze alignment. And this is the correction that we got, almost 30 degrees of correction. Now limitations were comparatively short segment fixation, incomplete restoration of horizontal gaze, and you might require another surgery for complete restoration. Thank you.